Welcome to the webinar. This is for the kind of makeup for survey preparation Cheryl Pacella is giving, and I'll turn it over to Cheryl right now.
Good afternoon, everyone, and thank you so much for participating in this session. My apologies to the folks out in Holyoke and in Methuen, because Colleen and I realized very quickly there is so much content, it takes a lot longer than we had originally planned to do the presentation today. Now, you should have received the handouts when you attended day 1 of our program, and all of the handouts I will be reviewing as we go through the session today. The one that I want to highlight first, and I'm going to ask you to please pay attention to this, you might want to even consider putting the sheets of paper back to back and laminating them. And these ones are the home health G tags and abbreviated identifiers. It is a sheet of paper that has all of the G tags for the priority standards for your state survey. The yellow reflect the second level priority, and the green ones are the highest level priority. So this is a very valuable document that you would excuse me, want to reference in the future. You also had a packet that was stapled handouts, and inside there is a checklist for a mock survey. This is a tool that I had created to use with home care agencies in order to assist them with conducting a mock survey. These are questions that could possibly be asked by the surveyor, but listed on this sheet also is the standard level, whether it is 2 or 1, and the G tag that it specifically references from the State Operations Manual. Next, I put together a Medicare Basic survey, and I'm sure that those of you on the call will be aware of the fact that some of these items you should very well know, and it's used as a tool to provide education with your clinical staff. So those are the handouts that I will be referencing as we go through the session. We do have approximately 1 hour scheduled for today's session, and I've asked Royce to please keep a tally of the questions for me, and we will allocate time at the end of the session for questions and answers. All right, so I'm going to advance the slides. We are all aware of the fact. Yes, Royce?
Did you tell them to type the question in the pane on the right-hand side?
Thank you for that reminder. Yes, in order for us to respond to the questions, on your right-hand side of the screen there is a chat box. So please type in the question, and as I said, I will take a look at that periodically, but we will have time towards the end to address the questions. So thank you for that reminder, Royce. All right, so the rationale for the program, we know in days gone by, agencies had a pretty good idea of when they could expect either their Joint Commission or DPH survey. But now surveys are clearly unannounced, and agencies need to be in a state of what I call ever-readiness. You must be prepared to have a surveyor walk in at any point in time, and in all honesty, that surveyor should be able to pick up any patient record or go out in the field with any particular clinician. So I think it's important that education and awareness be ongoing in regards to preparation for survey. Even agencies who do not have someone designated as a QI manager or director have the capacity to have a successful survey if you follow some of the strategies that I'm going to share with you today. All of the information and the materials that I am going to be talking about is available to anyone. Anyone can look up and research this information on the cms.gov website. Another website that we've included in our reference is the one for the Home Care Alliance, thinkhomecare.org. And if you click on the screens for regulatory and then go to Medicare, you will find the State Operations Manual. And I will reference that throughout the program and that's considered the Bible for state surveyors. Now, some of you may not realize the fact that there have been changes made in just the past couple of years. If you are scheduled for a survey between now, meaning November of 2013, and next May of 2014, you have not yet experienced the new protocol for conducting the survey. So that's why it'll be helpful for you to pay attention to the things that I'm going to be addressing today. Okay, so the benefits of this presentation: what do you need to know to be ready when the surveyors come knocking? When the surveyor does come knocking at your door, don't panic, take a deep breath, and hopefully after this session today, you'll be better prepared when the surveyor does come. Hopefully today you're going to learn some tips and tools, and you'll have some guidance in regards to preparing charts and also clinical staff for survey. You'll have a greater appreciation of the survey process. You'll be able to understand some of the recent updates and changes that have taken place, and you will learn how to identify any medical record documentation deficiencies. And if everything goes well and you have a deficiency-free survey, congratulations. But not everyone comes away from this deficiency-free. So I will be providing you with some guidance to develop a suitable corrective action plan. Some objectives specific to today's program. At the end of the session, you should be able to describe the survey process and the specific tasks that encompass the survey. You will be able to describe how to review patient charts to assure that the documentation and services are in compliance with the conditions of participation. You will identify the key elements for preparing staff for joint visits and explain, which will be new to many of you, the possible penalties for noncompliance. And when you work on planning for a survey, keep in mind that the chart audit tools that you are working with should encompass some of the key elements that I will be referencing today. There are penalties that will be kicking in most likely in July of 2014, and these are monetary penalties that you should all be made aware of. So basically, going through the agenda, I will be describing the survey process, the types of surveys, the difference between level 1 and level 2 deficiency, some of the process updates for conducting the survey. We'll describe the entrance interview and what to expect in the exit conference, and give you some guidance in regards to chart preparedness. There is an audit tool that I'm happy to share with folks, and I would advise you to conduct your audit tool so that it matches with your software system to make it easier to conduct a review. We also have tools related to potentially avoidable events, and just the importance of making sure that you have MD order documentation. So staff preparedness: what do clinicians need to know about joint visits with surveyors? You want to be able to have any of your clinicians prepared and ready to go out. A corrective action plan or plan of correction will talk about the improvement areas and how to word strategies and develop a proper and acceptable plan. And the penalties, as I said, you'll be learning more about these. A little bit of the history. The process for conducting the surveys was changed or revised in 2011. It was announced in February and became effective in May. The focus is now more data-driven and patient outcome-oriented. There is less structure and process orientation. The reference for this session is primarily the Appendix B of the State Operations Manual. Part 1 includes the information on the process, and as I said, many agencies have not gone through this as of yet. Actually, the history behind these surveys goes way back to the Social Security Act, and it was mandated that we have a process in place to make sure that the home care agencies are in compliance with the conditions of participation. If you do nothing else following this presentation, be sure to access and save on your computer, even print out that Appendix B, 3-hole punch the document and save it in a binder, front and center. Always keep it available because it gives you the guidance you need to have a successful survey. And use this manual as a guide for staff education, chart reviews, and performance improvement initiatives. So why do we have to go through this process? It provides the method for CMS to evaluate agencies' compliance with the COPs, and it also serves to ensure that provided patient services meet health and safety standards and a basic level of quality. The surveyors utilize the interpreted guidelines to guide them in the process. And that's where it's going to be helpful to reference that GTAG master. So if you can keep that nearby during the presentation, I will be citing that. There's a lot of guidance in the documentation, and one of them talks about the role of the surveyor. The surveyor is responsible for gathering information through a couple of different time points. There is the entrance interview, there will be patient and staff interviews, there will be home visit observations, and obviously clinical record reviews. The surveyor will come to your agency because he or she will have access and walk in with some of the most current information from your CASPER reports. They do have access to your OASIS outcome data. One member of the surveyor team should be an RN with home health experience. And we've seen some changes in the state of Massachusetts. In the past, they used to travel in groups of 2 or 3, but now it's typically 2 surveyors showing up at a particular time. And there may be a delay in terms of the timing of the survey. If you are expecting a triennial or 3-year survey, there may be a delay due to the government shutdown. Okay, so the types of surveys, you know, home care agencies that are just starting up will have an initial certification. It is specific to new providers, and there is guidance available for that group of people in the Appendix B that I have referenced. The standard survey is the survey that assesses the quality of care and the services provided by the home care agency. And there is an emphasis on the highest priority standards. These high priority standards are called Level 1 standards, and they address 9 out of 15 conditions of participation. So when you look at that green and yellow paper, the Level 1 are those standards that are highlighted in green. So those are the ones that you will want to pay particular attention to. Continuing with the types of survey, there is a partial extended survey, and this comes into place when there are problems that have been identified and the surveyor feels that there's a need to stay longer than the original allocated time. There is also an extended survey where there will be a review of all of the conditions of participation, and that type of survey can be conducted at the discretion of CMS or the surveyor. And the ones that you folks are most frequently dealing with are the recertification surveys. And the recertification surveys take place no later than 36 months from the prior survey. But having said that, I anticipate that some agencies will see a delay this year. These surveys, the recertification surveys, are conducted very similar to a standard survey. If a problem is identified, as I said, then the surveyor will make the determination to move on to a partial extended or an extended survey. Keep in mind that if your home care agency has multiple branches, chances are the surveyor will ask to review charts from all of the branches and do joint visits with some of the clinical staff from all of the branches. If a deficiency is found in one particular branch, the findings of that deficiency will apply to the entire agency. Now, I am going to call your attention to the Level 1 standards. As I said, these address 9 of the 15 conditions of participation, and the content is addressed here: patient rights, compliance with laws, organization services and administration, acceptance of patients, skilled nursing, therapy, and home health aid services, the clinical records, and the comprehensive assessment of patients. We'll get a little bit more into detail with some of these. Again, Level 2 standards on this document are highlighted in yellow, and again, refer to the handout. The Level 1 are the highest priority. Level 2 are the next highest priority. They do have different G tags, and you can reference these in the State Operations Manual. Now, I'm going to give you an example of how the Level 1 and Level 2 standards relate to each other. Keep in mind that the surveyor is initially going to focus on the Level 1 standards, and if he or she finds a problem in that area, then they would move to the Level 2 standard. For example, Level 1, G-Tag 236, a clinical record containing pertinent findings is maintained for every patient receiving home health services. A current, organized, and clearly written synopsis of the patient's course of treatment. That is the Level 1 standard. The Level 2 standard is the clinical record information is safeguarded against loss or unauthorized use. In other words, making sure that the charts are kept securely within the agency. If your agency is in compliance with the Level 1 standards, chances are that you are also in compliance with the Level 2 standards. So now let's talk a little bit more about the survey process. There are a number of different tasks that go along with this portion of the preparation for survey. Keep in mind that the surveyor will have access to information about your agency when they show up at the door. There is the pre-survey preparation, entrance interview, information gathering, information analysis, the exit conference, and the formation of the statement of deficiency. Your survey actually begins well in advance of them coming to your office. They have access, as I said, to a lot of your CASPER reports, and they will look at that information. They will also look at how you transmit OASIS data, the timeliness of that OASIS data, and actually making sure that your OASIS submissions are in compliance with regulations. I'm going to the next slide now. So pre-survey preparation, again, compliance with OASIS COPs. They will look, for example, at Tier 1, potentially avoidable events, specifically emergent care for injury caused by fall and emergent care for deterioration and wound. Those are the top 2 areas that are problematic with home care agencies. So if your agency has numbers that surpass the state or national reference in this regard, be prepared to have the surveyor ask for specific patient charts, and they will ask about your policies and procedures, for example, related to caring for patients with wounds. They will ask about the qualifications of the staff who are taking care of patients with wounds. You will want to pay attention to your patient outcomes in comparison to the national reference. And there is another tool that you will be learning more about when you attend day 2 of our program. And it's a tool that you can use with your own information from the CASPER reports to help you identify problematic areas. The surveyor also has access to the error summary report and inconsistent MU90 date of assessment completed and inconsistent sequencing. And I just want to caution you that I am hearing all across the state that surveyors are showing up with a list of patient names for whom there was only one OASIS submitted and there was no follow-up or discharge or transfer OASIS after the first one. Now, some of these are legitimate one-time visits when the patient may have had a physical therapy eval or perhaps a speech-language pathologist eval. Sometimes the patient may have only had start a care visit and may have moved or refused subsequent visits, but you need to make sure that you have an explanation or a rationale for some of these visits where there is only one OASIS. I know that some agencies have situations where the patient may have been admitted, but then someone failed to do the transfer, or someone perhaps failed to do the discharge OASIS when they should have. The entrance interview from the surveyors, make sure that the individual shows ID, and initially you will establish a rapport with this individual. You will sense that they maintain a sense of authority because of their position and their affiliation in terms of working with the Department of Public Health and CMS. The surveyor will request an overview of the home health agency structure. If you have not already done so, please make sure that you have an updated organizational chart that depicts who the people are and what their capacity is within the organization. The surveyors will ask for this information. The surveyor will also request a list of unduplicated patients, a list of current employees, and the names of key staff. The surveyor will also ask for access to patients for home visits, and we're all well aware of that. Okay. Some additional questions. Initially, when the surveyors show up, they typically would meet with the administrator or someone in senior management at the agency. The surveyor will ask questions such as how are complaints handled. They will want to review an admission packet, most likely specifically looking for patient rights and responsibilities. And here, I'm going to say this once, but I will repeat it again later. Make sure that you have information in the admission packet regarding the patient's rights to report complaints to the Department of Public Health hotline. What I typically do is circle that when the patient is being admitted, because if the surveyor goes to a particular patient's home and asks about that, chances are the patient will not recall that conversation, and then the nurse can say, look, in your paperwork, don't you remember I circled this so that you would be aware of it in case you needed it? These surveyors will also ask questions about staffing, how the agency monitors professional skills. They will ask specifically about home health aid supervision. And I'm just going to mention here, make sure that your agency policies and procedures match with what the expectation is in the conditions of participation. For example, we know that home health aid supervisions need to be conducted at a minimum of every 2 weeks. And it is not necessary for the home health aide to be present. Ideally, we would like that to occur, but it doesn't always happen. If your policy states that the home health aide must be present, this could be problematic for you folks. So please make sure that your policies do in fact match your practice and they are in compliance with the conditions of participation. The surveyors will want to ask how referrals are handled, the maintenance of records, and review with you the process for OASIS submission and transmission to the state. They will also ask questions as an aside about the agency's ability to take particular patients. For example, if the agency takes referrals for patients with a psychiatric diagnosis that is the main reason they're receiving home care, does the home care agency have staff qualified to take care of those types of patients? They want to make sure that you're only accepting patients for whom you can provide the adequate resources. So during the information gathering phase, this is actually a very organized and systematic approach to making sure that the agency is in compliance with the conditions of participation. The focus is basically on chart reviews, home visits, and staff interviews. Concerns raised may lead to additional chart reviews and/or home visits. Now, in terms of numbers, and all of this information is in that guidance in the State Operations Manual, if your agency has an average daily census of less than 150 patients, you can anticipate 5 chart reviews with 5 home visits. Larger agencies, you can see what the anticipated number is. For example, greater than 1,250 patients, you could anticipate 10 chart reviews with 10 visits. But in addition to these, you should anticipate an equal number of other chart reviews without home visits. So, for example, if you have less than 150 patients, 5 chart reviews for patients for whom the surveyor will be making home visits, plus an additional 5 records. Keep in mind that if the surveyors find an issue, they may request additional records. They are looking for patterns rather than isolated events. And we'll talk about the potentially avoidable events a little bit later. If there is an issue with patient falls or wounds, the surveyor may ask specifically for those types of records. They typically do look at the most current episode, but may go back to prior episodes. I had experienced a situation where the surveyor challenged us as to why the patient was being recertified. The next step is basically information analysis. The surveyors will review all of the information that they have gathered and make judgments related to the agency's compliance. They analyze the findings in regards to these specific areas: the effect on patient care outcomes, the degree of severity, frequency of occurrence, and impact on delivery of service. And I'll talk a little bit further about the specific joint visits with clinicians in a few moments. Now, after all of the information has been compiled, surveys typically take place, by the way, over the course of a week or 4 days or 5 days into another week. The exit conference is an opportunity for the surveyors to keep everyone within the agency abreast of what some of the problems are that have been identified. Usually, there are no surprises. At the end of each day, the surveyor may have a conversation with the leadership team to address specific areas of concern. But the purpose of the exit conference is to inform the agency staff of the preliminary findings of the survey. And as I said, there should be no surprises. This session, the exit conference, is typically attended by the administrator, clinical managers, and other invited staff. It provides an opportunity for the surveyors to thank the staff and to answer any questions that the staff may have. Following the exit conference, a formal written summary will be mailed to the administrator, typically within 2 weeks following the survey. And then the agency will have 10 days to respond and submit a plan of correction. There is a specific format for the statement of deficiencies. It's on this particular form, CMS Form 2567. It highlights the data tags that are assigned to home health agency conditions and standards found in the interpretive guidelines. The condition level and the standard level tags, and then it is worded such that it states the home health agency is out of compliance with, etc., etc., expected outcomes are not met for, etc., etc., and the statement of deficiency is written in language that any knowledgeable, reasonable person can understand. It's not very complex at all, but it does provide guidance in a simple, clear-cut wording for the agency. Now, Level 1 deficiencies. Level 1 is the highest priority standards. These are those most related to the delivery of high-quality patient care. Noncompliance with the standard tag will lead to a deficiency. It could result from one chart review or one home visit. So it only takes once to have a citation for a deficiency. This will prompt the surveyor to conduct a review of the Level 2 standards. I'm going to share with you another example. Say that the surveyor is going through reviewing charts and determines that the clinician failed to document home health aid supervision at a minimum of every 2 weeks. If the surveyor finds that there is a pattern in that regard, then the surveyor might take a look at one of the Level 2 standards, which has to do with making sure the home health aides have their hourly commitment in terms of in-services, 12 hours of in-services. If they find that there's a problem on the home visit, for example, regarding wound care or hand hygiene, they may move on to look at the personnel record of the specific clinician involved and ask for policies and procedures specific to hand hygiene or wound care. But those are just a couple of examples. With the Level 2 deficiencies, if there are problems found at this level, the survey moves to a partial extended survey. And at a minimum, the surveyor will examine the Level 2 standards. Deficiencies cited at this level could possibly prompt an extended survey to review all of the conditions of participation. And sometimes this is serious enough to put the agency in what is called immediate jeopardy, which is a crisis situation which does jeopardize patient safety. CMS or the state, as I had said earlier, may request an extended survey based upon the findings of the surveyor. So what do you need to do now? In order to prepare for your survey, please make sure that you have a system in place for conducting quarterly chart reviews. And I am often asked, how many records should we review? The standard is take a look at your average daily census, and you should conduct a review of 10% of your average daily census on a quarterly basis. So if you have an average daily census of 250 patients, you would conduct 25 charts at each of your quarterly reviews for a total of 100 records for the year. Now, if you are a larger agency, it's ludicrous to think that you're going to conduct 10% of the records. But for larger agencies, the minimum is 30 per quarter for a total of 120 charts reviewed for the year. You want to encompass in your audit tool the conditions of participation and perhaps anything in particular that your agency might be working on. You also want to take a look prior to the surveyor showing up. Do you have a policy in place within your organization regarding OASIS transmission and OASIS correction? So please make sure that your policies and procedures are reviewed periodically and that they are current. Always, always, always keep copies of your CASPER reports. My recommendation is to print these out at a minimum of quarterly and keep the most current quarter CASPER reports and take a look at what your potentially avoidable event numbers are as well. And if you have not already done so, pay attention to constructing and or revising your organizational chart. One of the things that I always recommend for agencies is to put together a binder, and inside this binder include performance improvement initiatives, some of the plans of actions for different projects that you have worked on. You would also want to include copies of the most recent CASPER reports, some information on patient infections, a summary of patient complaints, a summary of incident reports, and a summary of satisfaction surveys. This information has really helped to save me in the past. It also helps to keep some of the key information in one place. Many smaller agencies, as I have said, do not have the benefit of a QI manager or director, but someone within the organization needs to be responsible for compiling this information. Several people may be involved in overseeing different components. I strongly encourage quarterly performance improvement meetings to address the outcome measures and concerns that the agency may have. Now let's talk for a moment about the medical records. As I said, you want to be conducting periodic record reviews. You need to prepare a record review tool that encompasses the critical elements reflecting the conditions of participation. And you can use your GTAG master, or you can refer to Appendix B, as I had stated earlier. Conduct the chart audits to assess compliance. You need to know how to conduct a chart audit, whether it's on a paper system or an electronic system. And I am a big proponent of peer review. I really feel that it helps for clinicians to gain insight into what the critical elements are. And I hate to admit this, but I would conduct peer review and I would deliberately pair up clinicians. I would take someone who was a strong clinician and have that individual review the charter for someone who was a weaker clinician, and the hopes that perhaps the weaker clinician could learn from some of the qualities and the improved or better documentation of the stronger clinician. You might want to alter your tool over time. I'm going to give you an example. If your home care agency has a problem with wounds, you might want to add a couple of questions in regards to wound measurement, making sure that it's being done at a minimum of weekly. If there is something else in particular that you're looking at, perhaps even the therapy visits being done in compliance with the 13th, 19th, and the 30 days, you might want to address some questions to look at those areas as well. Now, as I said, the surveyors will most likely look at the recent plan of care, but they will pay attention to the admitting diagnosis and goals. Also, please make sure that you address in your chart reviews timely initiation of that first visit. Is the start of care conducted in less than 48 hours? Is there a complete comprehensive assessment? Are the medications written properly? Is there documentation of case conferences? And as I stated earlier, the supervision of the home health aides has always been problematic for agencies. But also, please make sure that you have a system in place for documenting supervision of PTAs, CODAs, and even LPNs. Now, in regards to the potentially avoidable events, these were formerly known as the adverse events. These are some examples here. I know that on the NAC website there are a list of chart audit tools listed under regulatory and resources, and we've even distributed some of the audit tools that have been modified with the new MOO questions, and the title was changed from adverse events to potentially avoidable events. If anyone would like samples of these tools, I would be happy to provide them to you. In regards to staff preparation, it is a lot to stay on top of everything, and you want to make sure that any of your clinicians is ready to go out with a surveyor. I try to make the education and training fun so that you can get the message across. Some of the things that I've done in the past that have worked well is one, for example, is Joint Commission or JCO Jeopardy. And you can just Google Jeopardy and you can create this online. I've created crossword puzzles, developed modules, and even had little quizzes, and people who submitted the responses to the quizzes would have their name entered into a drawing for a prize. I think it's important that we provide the education on an ongoing basis and not just in the couple of months leading up to a survey. Remember, a surveyor should be able to go out with anyone. And on the next slide, we're going to talk about planning for joint visits. I highly, highly recommend that someone within the agency goes out with the surveyor. Do not leave the surveyor alone with clinical staff for any period of time. My biggest concern is that the staff may offer information that you do not necessarily want to share with the surveyor. You need to be careful about those impromptu conversations. I know that when I worked as the director of a home care agency, I accompanied the surveyor, and we talked about things like our grandchildren and the weather and things such as that. Do not offer any information. Wait until you are asked. These are some of the things that clinicians in particular need to pay attention to. Make sure that they are all complying with your bag technique policy, hand sanitization, the storage of equipment, maintenance of equipment. Make sure that, for example, if your staff are using glucometers or if they are using INR machines, that they're following the agency's policies in regards to quality control checks and cleaning of this equipment. One area where people often get dinged is in regards to changing gloves. If your policy states that clinicians must hand sanitize before and after donning and removing gloves, please make sure that they are abiding by that, even if it's as simple as using the gel. People can get cited if the nurse removes gloves and puts on another pair of gloves without washing her hands in between. So these are just some of the things that you can do to prepare your clinicians for this. Okay? Now, informal dispute resolution, this is going to be going into effect in July of 2014. There's going to be a little bit of a modification in regards to when there is a problem that's been identified. The home care agency will have an opportunity to resolve disputes in certification findings. They may settle disagreements prior to a formal hearing, or they may ask for an informal dispute resolution, which must be submitted in writing. Next, I'm going to talk a little bit about the plan of correction. In the plan of correction, as I stated earlier, you have 10 days to respond. You need to encompass all of these items that I have listed here when you're writing up your plan of correction. I'm not going to go through all of this information because you have it here in front of you, but the plan of correction needs to be specific in a particular format. So if you pay attention to these bulleted items, your plan of correction should be fine. Next, I want to spend a little bit of time talking about the penalties. Last year, or actually 2013, this past spring, we had the New England Conference in Foxwoods, and Bill Dombey was there, and he spoke about the penalties that are going to be going into effect. And there are serious penalties, and some of them have a monetary component that you need to be aware of. So this is some information regarding the penalties. And actually, these slides, a portion of them were taken from the Home Care Alliance website under thinkhomecare.org. There was a session that Colleen had conducted last year regarding some of the penalties that we can expect. So here it is, folks, the monetary penalties. If you take a look at this, if you are a mid-range size agency, the penalties could be as high as $2,500 to $8,500 a day. So this can be very serious, especially if it's going to put an agency into immediate jeopardy. So pay attention to these things, and I'm sure that you will be hearing more about it. In regards to recent updates, the state survey agencies due to receive 2.5% to 3% budget reductions as a result of sequestration. So there is going to be less of a focus on the Target 2 type of surveys to low-performing agencies, and then no agency has gone longer than 3 years, so hopefully, you know, those of you who are anticipating your 3-year will still have that type of survey going forward. OIG report, this is some information that came out in April. For the sake of time, I'm not going to read through each bulleted item, but the good news was that most of the agencies who were found to have deficiencies, 93% of them made corrections within a 3-month time period, which is good to know. Again, following up on the OIG report, this is some information continuing about the survey process. And one thing that I was not aware of, and I had learned about doing this, is that the surveying agencies in each of the states can conduct what is called a look-behind survey. A look-behind survey is a survey that takes place and is conducted by the state surveyor when an agency has already had a survey, for example, by Joint Commission or CHAPS, and they are what is considered deemed status. What CMS is doing is looking at making sure that Joint Commission or CHAPS are doing things that are actually in compliance with the conditions of participation. And having said that, that's a segue into a little bit about Joint Commission, CHAP, and the Accreditation Commission for Healthcare. And these are the links for those particular sites. Now, I know that a number of agencies in the state have decided to abandon Joint Commission, but there are still a fair number that maintain an affiliation with a hospital. In regards to the Joint Commission, we have a number of the standards here, and basically what I want to say to you is that 2 of the standards in particular are perhaps the most problematic. The standard that is most often cited pertains to the organization's ability to provide care in accordance with physician orders. The next problematic standard is that under infection control in regards to hand hygiene. Those agencies who are accustomed to working with the Joint Commission are very familiar with some of the tools that are available, and these include the Survey Activity Guide. An agency should have identified PFAs, or priority focus areas, and there is also what is called the FSA, Focused Standards Assessment. This is an easy tool that you can use to conduct a mock survey within the organization. Again, these are some more slides pertaining to the standards. National Patient Safety Goals. I can tell you that the big emphasis this year is going to be on oxygen safety. So please make sure that you have somewhere written in your teaching materials you're using with patients information about oxygen safety. I talked a little bit about deemed status. So deemed status, we're seeing that it's interesting. Fozzie and Associates came out with this in one of their newsletters. The number of Medicare certified home health agencies increased by 23% from 2008 to 2011. Of these agencies, the number of those with deemed status increased by 255%. That's an increase from 12 to 34% of all Medicare certified home health agencies. Now it's interesting because I know back in the day I had been at the VNA of Boston, and literally right before, you know, the start of the year, we had Joint Commission show up, I believe, on a Friday afternoon, and then on the following Monday, we literally had the Department of Public Health. So that can happen, but for those agencies who choose deemed status, then they can get away with just having the one survey with Joint Commission. But of course, that does come at a fee. Okay. I have, as I said, some of the attachments, and I'm going to perhaps have Royce send out, for example, the potentially avoidable event tools, because I want to make sure that people have access to that and can utilize those tools to look at their potentially avoidable events. Quotes. I'm going to end with this quote. We are what we repeatedly do. Excellence, then, is not an act, but a habit. If we do things in compliance with the regulations day to day, week to week, month to month, year to year, then it really should not be too cumbersome to go through a survey. The next quote is actually from Quality is Free. Quality is free. It's not a gift, but it is free. What costs money, and think about those penalties and writing up the corrective action plan, are the unquality things, all the actions that involve not doing our jobs right the first time. And at this point, I'm actually going to turn this over to Royce to see if there are any questions.
I don't have any yet. If you have a question, type it into the question on the right-hand side of your screen, and I'll get it. So let's give it a few minutes.
That's fine, everyone. I can tell you that many of you on the call may be actively participating with the Home Care Alliance QI committee meetings. And when we have our meetings, one is actually scheduled for next week, we typically go around and share recent information regarding the surveys. One of the things that I wanted to tell you is that I am seeing fewer instances of where the surveyors are asking for personnel records. If everything looks okay and the agencies are in compliance with the level 1 standards, the surveyors may not delve that deeply into the personnel records. And I think that that's kind of a good thing, but please make sure that you're paying attention to your personnel records as well, especially in regards to checklists or skills checklists. And if you have, for example, home health aides, making sure that they have their 12 hours of in-service. And I think for the most part, the surveyors work very well with the agencies. They do allow you some time to compile and get all of the information that they are looking for. So please, I wish you all well and good luck on your upcoming surveys.
Still have no questions? They can also email me and I can get them to you, Cheryl, or they're going to see you again at the day 2 of both of the clinical compliance intensives, so they could probably ask you then too, either way.
That's great. I look forward to seeing folks in December. Thank you.
Oh wait, I do have 2. Can you explain more on civil penalties, number of days that would be typical for a deficiency?
The civil penalties, all right, I have to go back to that slide for a moment. This is still fairly new information, and I would encourage you, as I said, to go to the Home Care Alliance website. There was a presentation that was given, and some of these slides were there. And basically, you know, if they determine that the agency is putting patients at serious risk, then they will initiate these fees or penalties, and the agency really needs to make sure that they're on top of specifically the level 1 standards. So if there is something found, then, you know, there is a risk. If you're out of compliance at level 1, you could potentially be cited for some of these fees. We will probably learn more about this. As I said, Bill Dombey had said that he expects this to go into effect next July. So I would anticipate you will be hearing more about it, if not just from the National Association of Home Care, but also from our state association. But for more detail, I would encourage you to visit the Home Care Alliance website.
Are there only 2 levels of deficiencies?
That is correct, level 1 and level 2. And if you download, I encourage you to download the state operation manual, and it highlights specifically all of the level 1 and level 2 deficiencies. There's no such thing as like a level 3 or a level 4. But as I said, the level 1 covers, I believe I said, 9 of the 15 conditions of participation that apply to home care. And the level 2 also address the conditions of participation, but at a different level. And that's why I gave you the example for like, say, the home health aid supervision, the home health aid in services. If they feel, for example, that your nurse is not really skilled providing care to a patient, perhaps she doesn't really know how to do a procedure, for example, wound vac or Fluorex or something, they may ask to look at the personnel record of the nurse to see what education or training or how someone determined that the nurse was proficient with that. So there is like a correlation between some of these things. If they determine, for example, that, you know, you are not maintaining your charts securely, then they will dig deeper into the policies and procedures within the agency, and they would conduct a more in-depth review. But it will help you to take a look, as I said, at the yellow and green on this GTAG master, and focus first on the green, and if there is a problem with that, then they will specifically go into the yellow ones.
Okay. Can you address infection control and the need for a barrier between a laptop and the home under DPH survey?
Okay, I can share with you the experience that I have had with a couple of agencies. Make sure that the practice matches your policy. Now, I know sometimes policies are created, but policies can be modified. Pay attention to your policy. Make sure that the clinicians abide by your policy. I know that, for example, we all know that you should not put your clinical bag on a soft upholstered surface for multiple reasons. And most of us have a policy that states the bag must be on a hard, clean, dry surface. Now, the clinician in a patient's home can make the determination, is this a safe home that she wants to bring her equipment into, or possibly may need to leave it in the car. It depends on the policy. I have seen successful state surveys without having a barrier with the laptop. So, you know, again, go by your policy, and that's the most important thing I can say.
Please review the quarterly chart review.
Review the quarterly chart review. Your agency most likely has an audit tool for conducting quarterly chart reviews. Now, as I said, the minimum is 10% for smaller home care agencies, or 30% for larger home care agencies. And I know that agencies I have worked with typically have a tool that addresses the conditions of participation. So you want to make sure, for example, that your visit frequency matches the doctor's orders, that disciplines are involved and that there's communication, medications are written properly, et cetera, et cetera. Most of us have those types of tools available. If anyone would like a sample tool, I will be happy to provide that to you. And sometimes agencies will focus on a specific problem. For example, if you're putting in place a protocol for wounds or something to do with fall safety and therapy, you may want to modify your record review tool. If you identify that there's an issue with potentially avoidable events, you might want to use some of those avoidable event chart audits as part of your quarterly requirement.
that's all the questions I have right now.
Great. If anything else should come in, I will be happy to address it. Thank you, everyone.
Thank you. Bye-bye.